I'm Susan Johnson, and I'm the state representative from Connecticut. And I'm just recently, this is my first term as the House Chair of Public Health. But I think that some of the reasons that I'm here today to talk to you a little bit about the Affordable Care Act and Medicaid and some of the transitions that we have gone through since 1996 when we adopted the Medicare Managed Care program in the state of Connecticut. Because I have been an advocate for Medicare beneficiaries from 1979 to about 2000. And also in that work, I worked with the Medicaid population and where Medicare and Medicaid dovetail. So we have been working with, I've been working with complex care interchanges between Medicare and Medicaid for a long time. And, but some of my presentation is just a little bit of the history, just to get into a little bit of perspective on what Connecticut has been doing for the last several years. So there's the history of the Medicare Act, and I'll go through these very quickly just so that you see that, as you know, we've said this a lot of times in a lot of different ways since yesterday. The states contract with the federal government for the kind of plan that they want, and we have a very comprehensive plan in the state of Connecticut. We have these mandatory coverage groups for basic Medicaid, and then of course there are the optional coverage groups. We call our Medicaid programs the Husky program after the University of Connecticut's team, the Huskies, and so we've named it the Husky program. We have Huskies A through D, depending on whether or not you're a family with children, a family with a little more income with children, if you're disabled, or if you're a combination of people who have Medicare and Medicaid. So a little bit of history. We, back in the 70s and 80s and into the 90s, we had a program in our state that was called Town Assistance. Town Assistance took care of people who didn't qualify for the Social Security Disability Program. And Town Aid also took care of the medical services. So we had that, and it was changed over to a regular state-operated program in the mid-90s, just about the same time that we created the State-Assisted General Assistance Program, which took care of a lot of the Town Aid beneficiaries who probably should have been making a transition to Social Security disability, but quite hadn't figured out how to do that, either because of the severity of the disability or the newness of the disability. So we created the State-Assisted General Assistance, which was totally 100% funded by the state of Connecticut. And so that went along fairly well until we realized that under the new Medicaid programs, we could have a low-income adult program and get 50% reimbursement. So there was some hesitation by the state to sign on to that program, but we did that. And once we did, and we opened up the eligibility, we were simply stunned by the numbers of people who made an application. And we found that we were under budgeting for the low-income adult program. And we began to look at the cost and say, gee, maybe we need to seek a waiver. But fortunately, for the adults in that program, we were able to continue to provide the funding, and now under the Affordable Care Act, the low-income adult program is morphed into that, and we're going to be receiving the 100% reimbursements for that. So we, of course, the Medicare Savings Program is one of those intersections of Medicare and Medicaid where you have people who are in the Medicare program, but also for the co-insurance and deductibles can obtain qualified Medicare beneficiary coverage and also a Medicare D for the prescription drug program. We have a wraparound that covers that through the federal government, and those are some of the income guidelines and how that works. It's also family planning under the Affordable Care Act would be covering up to 250% of the federal poverty level. And both Medicare and Medicaid have the 5-year wait period before they can obtain the coverage. We have mandatory services, again, showing that this is a comprehensive plan that we provide to people in Connecticut. And we have we have a little more than 500,000 people in a population of 3 million in Connecticut who are on the Medicaid program. And of course now we were receiving around 50% reimbursement from the federal government for the Medicaid services that we provide, but we're going to be getting the 100% reimbursement as of January 1st, 2014. We also took advantage of the cost-sharing programs that are allowed with respect to patients on Medicaid who utilize emergency room services and have a small cost sharing program there, so that there will be hopefully a return to not overutilization of emergency room services. And we also did that with prescription drugs, but it worked out where the pharmacists were really very unhappy with that because it was very, very difficult for them to provide the medication and get the reimbursement from people on Medicaid who have such limited incomes to begin with. So that program kind of fell by the wayside, and making the pharmacists do that work was very, very difficult. A couple of years ago, we changed our employee benefit plan for the state, and we had more mail order type situations for the pharmaceuticals, so that there would be a reduction. We saved almost $50 million in state health insurance plans. But what happened is the local small independent pharmacies found that they were stuck with the Medicaid population. And they were stuck because they're not getting the full reimbursement, and then they lost the insurance coverage. So it really made a difference. And if you're looking at your tax base for your local community and you want to make sure that your local pharmacies are actually paying some property tax to help move things along, you don't want to squeeze these small providers, these small independent businesses. So we stopped doing that with a co-payment. We created back in 1996, when we went to Medicaid managed care, actually in 1994, we went to Medicaid managed care, a medical oversight council. This was a combination of legislators and providers and the executive branch coming together to monitor exactly how well the Medicaid managed care program was going. It really provided a good exchange. We have we have 5 subcommittees: care management, complex care, which really involves the Medicare, Medicaid, and disabled population, consumer access, quality improvement, women's health, and we were able to manage that. And one of the things that I found interesting is when the state went from the fee-for-service to managed care, we actually found ourselves spending a little bit more money than we did initially. But after the transition occurred, there was really little or no data information, no real financial information. Of course, you have the capitated system where you pay on a per-person basis for managed care, but where there was no data coming from the organizations that we had contracts with. So we began to hear complaints from consumers of the healthcare that this was not working out. People were having a hard time finding a provider, to cardiologists, gastroenterologists, all different types of providers. They were really having a hard time getting access to healthcare. So in about 2006, we had some people from Yale trying to do a study and asked for information from the state of Connecticut, which the state was unable to provide, and I'll get to that in just a minute. So the transition occurred because of the lack of the ability for us to get the information from the providers, the Medicaid managed care organizations. They refused to provide the data that we asked for. And part of the data problem was that the reimbursement rates were so low, the access was very, very limited. So cardiologists, gastroenterologists, all those types of providers were not willing to be part of the network and provide services. So I've listed that it's HealthNet versus the Freedom of Information Act because they had said, hey, this is public information, this data should be available, you should be able to access the data. And HealthNet said, oh, well, we don't want to give that. We believe that that's proprietary information. It's a trade secret. And so we had two decisions, one in 2006, which said, yes, you're subject to the Freedom of Information Act. You have to be able to give this information because you're, as a Medicaid managed care organization, you're doing more than just selling, say, for example, they listed shoes, which is something that, you know, wouldn't require much in the way of public policy making. And because managed care organizations with the state are actually making policy, they are making policy, healthcare policy for the state, depending on how well you define what you're going to do with your contract with the managed care organization. They have to be part of the policy making, and part of policy making is really something that you want to have, you know, input into as a public. So they ruled against HealthNet, and the information was provided. Then McKesson Health Solutions the following year said, well, maybe it's public policy, but perhaps what we have here is under the Uniform Trade Secrets Act that Connecticut has adopted its own. We are unable to provide the software and this data, and the court again held that yes, the data has to be provided. It's not a trade secret. The Uniform Trade Secrets Act was created really for industrial espionage, and you're providing health care and health care policy as was determined in the previous case the year before. So there was still a hope that the state could work with some of the organizations as managed care organizations, but after trying to work through that, we went with former Governor Rell and terminated the managed care organization contracts so that we would be able to access and provide information to other organizations. Yale University was trying to figure out what was going on and maybe provide recommendations on better healthcare delivery systems. And so when Governor Malloy became the governor, and this is all occurring at the same time that we're going into the Affordable Care Act, and at the same time that we're going from managed care to administrative services organization, which as we've stated here before, the managed care organizations, they create the policy, they also absorb the risk. Here, the state will be absorbing the risk, but we'll work with an administrative services organization, which acts pretty much like a third-party payer in a self-insured program. So, so that's really what we did. Now in 2012, we created this ASO. We started meeting with our Medical Assistance Oversight Council, all the different subcommittees working with the organization to make sure that we were connecting on all different levels, and how can the ASO help us? How can we get these healthcare delivery systems put together in a way that'll work? And so we had started on using the concepts of patient-centered medical homes and health neighborhoods, and structuring them so that they have complete networks, because we didn't want to have these regions without complete networks. And that was one of the problems that we had run into, not just with Medicaid managed care, but also with Medicare managed care, because I'm sure you all remember all throughout the 90s, we had a situation with Medicare managed care where we had the managed care organizations going into the states saying, hey, you know, we can save you money, and then it turned out, well, the managed care organizations were actually not able to save money, particularly when you got into more rural areas. They just didn't function well at all. And when you got into the urban areas, we found that they were spending more money on a per-person basis than regular fee-for-service Medicare. So we had that difficulty as well going on at the same time that we're trying to make this transition to first the Medicaid managed care organization, and then now to the administrative services organization. So we applied for a grant for the Center for Medicare and Medicaid Innovation, a planning grant to help with a 3-year pilot program, so we'll be able to try and make sure that what we do with the complex care group, that's the Medicare, Medicaid disabled population, whether or not they will be able to provide services in a more cost-efficient way using medical neighborhoods, prison-centered medical homes, those kinds of things. And so we have about 64,000 people that are Medicare, Medicaid eligible. 57,000 of our participants will be able to work through this program with the ASO. So we have integrated the Medicare, Medicaid long-term care, behavioral services and supports to help us move into this transition. And we've been spending a lot of time setting up our relationship with the ASO so that we'll be able to have a healthy network, be able to do evidence-based reimbursements. If we have evidence-based reimbursements, that is reimbursements based on the effectiveness of the healthcare services that we're providing, then in those circumstances we'll be able to say, yes, we've had a success in terms of intensive coordination of services, electronic health records between providers. All these things will work to, we believe, reduce our costs, keep the state in touch with what's going on with respect to the Medicaid program so that we have the data, we have the statistics ourselves, and we'll be able to run the program ourselves. So we'll use that shared savings model, and that'll be administered by the administrative care organization. So the structure is this. You have the medical administrative care organization that oversees the person-centered medical homes, the fee-for-service providers, behavioral health administrative service organization, and the Medicaid and Medicare eligibles pilot. And under the Medicare and Medicaid eligible pilot program, we're going to have 3 to 5 medical neighborhoods that'll be operating these person-centered medical homes, and will fit right into the right sizing that we have also. Another way to cost control our skilled nursing facility population by changing the balance there and moving more people into the community and out of institutional care, which is something that we need to do. We know that many of the other states are already doing that, and they're saving money, and we need to be able to create a situation where people will be able to move into from the skilled nursing facility back into the community. This is going back a little bit to what we had with the independent pharmacies and trying to address some of the difficulties they were having, because they mentioned that independent pharmacies, or any pharmacy that provides services of medical prescription drugs to Medicaid patients, generally does a lot of counseling on how to take the medication. It's not quite as easy to deliver prescription medications to Medicaid population as it might be for someone who has a little more background in how to take the medication. And this, again, this goes a little bit into how we sought the waiver, and then we went into the Affordable Care Act for the low-income adults. So here's the summary. We had the public health insurance, collectively referred to Husky. We also had the Charter Oak program, which was for the population of people who wouldn't have qualified for a Medicaid Husky program because they weren't categorically related to a government program, which was one of the requirements before the Affordable Care Act for getting Medicaid services, or medically needy program, which is optional for the states that we happen to take as a part of our plan. And so this Charter Oak program is significant because it was a program set up for people who couldn't get insurance. So if you had a pre-existing condition, the costs were so high that you had to be able to try and access some type of insurance plan somewhere. The Charter Oak program was the plan to go to. And then we instituted a low-income adult program. Well, what do you think happened? All the people, almost all the people from Charter Oak went into the low-income adult program, excuse me, but what happened to the few people who didn't qualify for low-income adult? Well, the premium skyrocketed because the pool of people was significantly decreased, and they were unable to afford that. So now they're in the low-income adult program. So that's about it, and thanks so much for your attention. And